Welcome to the Chef Talks inaugural talk. So, my name is Ernest Davis. I am the Chief Ambulatory and Ancillary Officer for Presence Health Northwest Chicago region. Very long title, I know. I am also the President-elect for the Chicago Health Executives Forum. We are the largest independent chapter of the American College of Healthcare Executives, and here to service you, the healthcare leaders of Chicagoland. So again, thank you for joining us today. Please do follow Chef on Twitter at ChicagoACHE. We're going to be talking about chronic disease, and specifically we're going to be discussing the impact of diabetes on the care processes, both on the patient and how the different vendors, the different industry executives that are charged with taking care of patients with diabetes and all chronic diseases interact with each other and interact with the patient over time. You might ask, why did we choose chronic disease as the topic to kind of pivot off of? Well, 45% of the American population has one or more chronic diseases, and 7 of 10 deaths in the United States can be attributed to chronic disease. So while it is a public health concern, it is also an administrative concern as we try to bring all of our resources to bear to take care of patients that have chronic disease. There's a great deal of discourse within there on the provider side as well as on the patient and caregiver side. So we want to try to not berate the current system, but inspire everybody to know that you're not in this alone and to give you some tools and some best practices that might help you to better take care of the patients that have chronic disease as you go along in your day-to-day work. We're going to cover a number of different segments of the care cycle, from diagnosis to treatment to management. And it's important to know that every 5 minutes, 2 people die from diabetes-related causes, and 14 adults are diagnosed with diabetes, newly diagnosed with diabetes, every 5 minutes. So there is a very good reason for us to be here today. For us to move through our conversation, we thought it best for us to first start from the patient perspective. So Aaron is going to come up and talk to us a little bit about what he and his family went through to take care of a patient with diabetes.
Good evening, everyone. My name is Aaron Wiles. I'm the Director of Cardiopulmonary Labs over at Lurie Children's. I want to come today, and I want to first thank you for allowing me to share my family's story. My family story starts about 10 years ago. My stepbrother and his wife were married, and they were looking to expand their family. They tried naturally to have children, of course, and unfortunately were unsuccessful. They decided to look at other avenues and looked at in vitro. They had 3 different pregnancies that all ended in miscarriage, unfortunately. They then started looking, saying, how else can we do this? How else can we grow our family? I know we're going to be great parents, and they are. They're amazing. So they looked into adoption. They found an organization that had the same values as they had, and within 6 months, they had an opportunity to adopt a beautiful, perfect boy named Garrett. Garrett is, he's a character. He's full of joy. He's always full of energy. He has been since day one. And actually, the first day I got to meet him was on my wedding day. It was just strange timing, but that was the first day they could bring him home. And we got to go to my wife's and my wedding, and you look back at pictures and you see this sheer joy in their face, knowing absolutely they had nothing to do with me. Nothing. But no, it was great. It was a great story, and as all these stories seem to go, 9 months later they find out they're pregnant, right? They find out they're pregnant, and everything works perfectly. The stress is off, everything works perfectly. And all of a sudden their family has gone from 2 to 4 quite quickly, and life gets hectic. Life gets hectic, and you know, it's 2 boys to, you know, as some of you may know, it's a lot of energy in the house, a lot of testosterone. But 3 years later, Garrett is potty training, and they're noticing that they're not making any progress. But not only are they not making progress, they're seeing that he's filling his diapers rapidly. He's doing it in copious amounts, and that was strange enough. But then all of a sudden, they start seeing that he's becoming more and more lethargic, and they can't explain it. That's a red flag. They go to the doctor's office. The doctor sends them to the hospital, and that hospital visit turns into a 5-day stay. His blood sugars were grossly out of control, and they warned that if it would have, you know, been out much longer, it could have been very, very serious. So naturally, these are young parents. They get these, they're, you know, their first baby boy is going through something very, very concerning. And all they know about the disease is that my stepbrother's grandfather had lost limbs from diabetes, and so that's in their head. They don't know what this means. They don't know what this means. They don't know. They're trying to search for anything that will make them make this, you know, seemingly shaky world all of a sudden stable again. And so they start looking for education. The healthcare workers in the hospital are doing their job. They're acting calm, trying to keep them calm. But to Chris and Tina, their world, again, has been shaken, and they need to know that these healthcare workers are taking it as seriously and care as much as they do. They start searching for education anywhere they can find it. They start, with the internet, and of course they're being given handouts, but it's so much on a handout, so much that they couldn't focus on it. They started looking in the internet to see where can I find information, and they thought, why not go to my hospital, the children in mid-Missouri, the Children's Hospital's website. They have all the specialists, they have all the professionals. That's where the information should be. They go to the diabetes website there, and they leave that experience more confused and scared than they entered. So now, we're trying to figure out, like, what's the ways to make this better for patients. And, eventually Garrett got the information he needed, and his parents got the information they needed to make sure that they could teach him to take care of himself for the rest of his life, and to make sure that they could take care of him until he's able to do so. But it took a long time, and we shouldn't have parents and families working that hard to get this information. And so this experience has inspired me a lot through my career, and making education, making patient experience a priority. One of the first things that I've done in my career when I get to a location and I feel like I can make an impact. Of course, you've got your normal duties, but then you look at trying to make the patients make sure they're aware, they're educated. So you're making pre-visit calls, making sure everything's scripted, make sure the patient is fully educated. You're making a discharge card so they know the next steps. Recently, I got to work on a wonderful team. One individual is actually here tonight, Mark Senger, with the Thrive Leadership Program over at Lurie. And we got to take it even to a next step, to where we got to talk to these stakeholders in endocrine and said, how can we make this experience better for your patients? And we were able to work with them and their insight to revamp education, make it standardized, get it in multiple languages, get a video recipe that's kind of put out that a nutritionist has vetted and made sure that it was actually healthy, and put it on video. So we're crossing language barriers, we're crossing literacy barriers, and what we're trying to do, and it's still in its development stage, what we're trying to do is make this where it's outward facing. So the next patient that does go to a children's hospital or adult hospital and they say, I need to know more about my disease process, they can go to the subject matter experts and know that information is there. And it'll constantly be reinforcing their education because it'll always be there. They won't have to worry about walking out with handouts and losing those handouts and what now. This will always be there for them. These are just some of the many steps that we could take to make sure that our patients are fully educated and the patient experience is strong. We know that education it's best when reinforced. You have increased compliance, increased outcomes, and so on. So it's really something that's very, very near and dear to me, and I found that's been very helpful in my career, and I hope this helps you in yours as well, because this is a worthy cause. All right. Thank you all.
So thanks for having me. I did make it all the way in from Indiana, and I saw an awful lot of Hyde Park on the way in, so I greatly appreciate it. I wanted to, hopefully, I don't know how many of you have bedside experience, but some of you do, some of you don't. I have a lot of bedside experience and a little bit of administrative experience, so I'll probably concentrate a little bit more on what I'm comfortable with, which is the bedside experience. I really kind of wanted, I take things literally. Craig Miller, who I also work with, will attest that I'm fairly black and white and literal. So I heard patient experience, I said, well, I can do that. So I hope that I can give you a little bit from the patient's perspective as well as from the physician perspective of how I experienced diabetes in my career thus far. So the title of it again is patient experience, and I really hope I can capture the experience by just describing to you 3 patients that have stuck in my brain over the past 20, 25 years since I've been out of medical school. I hope to describe them to you and hopefully capturing a bit of them personally. They've passed since then, but hopefully a little bit of them will live on in what I say clinically and reflect on their experience and what it must have been for them as a patient experiencing the ravages of diabetes. That I've known, her name was Audrey. Audrey's a 21-year-old diabetic who I actually was consulted on because she needed a kidney pancreas transplant. And at that time, Audrey was just a wonderful young woman, and she was cared for by a very loving and protective mother. When you met her, she was polite, demure, quiet, very intelligent, and very into her care. She wanted to go into the medical field, but because of the ravages of her disease, she really had a lot of difficulties with disability. She suffered from very brittle diabetes, spent a lot of time in the hospital. And most of the time in the hospital, you know, it was just one new complication after another. Her body was ravaged by her disease, leaving her with neuropathy, partial blindness, gastroparesis, heart disease, vascular disease, progressive kidney failure. And if that wasn't enough, she had been managed by in a system where her pediatrician was following her and then handed her diet to a family practitioner, and most of her subspecialty care within her HMO was gotten through instances at the hospital. So she would get subspecialty care through there. When she saw our service, which was a nephrology service, I'm already at the end stage of things, and she was being evaluated for a kidney pancreas transplant at that time. She did receive her kidney pancreas transplant. She had some success with blood sugar management, and she was actually able to go back or go to work and become a medical technician. Unfortunately, she gradually rejected her kidney pancreas transplant, and which she received here at Northwestern, actually, and she went on to require dialysis. She passed away from vascular complications soon after she initiated dialysis. Despite the harshness of the disease, and the brevity of her life, Audrey left a lasting impression on me as a clinician, as just being a beautiful young woman hoping and fighting for really some reprieve from her illness, which she unfortunately never received. Let's see. Next, I remember a patient by the name of Jim. Jim's about 55 years old and type 2 diabetic, 20 years. I met in the office, and he well, let's just say didn't care for himself very well and let himself go for 20 plus years. He was dedicated to maintaining his business in northern Wisconsin, so he and I got along quite well. At the expense of that, though, he had terrible control of his blood sugars and commonly had glycosylated hemoglobins greater than 13. He was a great guy. He was fun to have in the office. He was polite, appreciative, chivalrous. He cared for other patients even while he was in the office and in the hospital and eventually in the dialysis unit. He had a dedicated wife that struggled with his stubbornness for years, and They would come to my office about twice a year because they spent the other half of the year in Wisconsin taking care of their business up there. So again, his care was very disjointed amongst subspecialists, primary care, different locations. So he really struggled with managing his diabetes. We would talk about his disease and its progressive nature. I would be the very astute clinician and tell him blood sugar management, hypertension control, ACE inhibitors, decrease your protein, don't smoke, do all of those things that we tell them to do, all to hopefully limit the progression of the disease. And we would talk about fishing and we would talk about the badgers because that's what we do. Jim went on to have a predictable decline in renal function and a predictable non-compliance to his blood sugars. And I initiated him on dialysis, and which turned out to be lifelong dialysis treatments. He and his wife divorced. He suffered from terrible vascular disease, lost his leg to gangrene. Despite the setbacks, he continued to travel up north, insisted on maintaining some part of his life that he considered was normal. And he died from sepsis after suffering a recurrent gangrene of his lower extremities. He handled the merciless progression of his disease better than he handled the daily management of his disease. Despite the sequelae of his disease and the inconveniences of his life, he left a lasting impression as a good old boy wanting to squeeze the best out of life. To this day, I consider him, he was a really cool guy who just didn't do well with the disease. Lastly, there's Don. Don was a 6-year-old morbidly obese gentleman, type 2 diabetes for an uncertain number of years. He didn't really care to think about it, who I also had in the office. He was a true Southsider. I don't know how many of you are from the South Side of Chicago. I happen to be a South Side native. He was an entrepreneur and had some means. He had very little use for people and very little, and even less so for doctors. So he was very full of himself. He spent most of our conversations telling me what was wrong with his town, what was wrong with his state, what was wrong with his country, and all of this was done showing his personal biases, which he exposed everybody to, and it was just not a wonderful experience. He simply wasn't the nicest guy around. He was married, but I never recall him ever meeting his wife, so I'm not entirely sure he was married, but that's what he told me. Don was the patient to me that I quite frankly would see on my schedule and hope he didn't show up. So I'm just being honest. And our meetings were contentious, they were uncomfortable, and looking back, and likely attributed to my own Southside grit, I fought with him constantly. I have no idea why the guy stayed with me as a physician, because we never had any points of being in agreement. But through some divine intervention, which he certainly would not have believed in, I was finally able to convince him that he was obese and that maybe bariatric surgery could help him. And I explained the potential for the improvement in his proteinuria and the renal insufficiency and how it would help him. But overall, I told him, you're fat. It's going to be better if you can have bariatric surgery and you qualify. So I wasn't really looking at it from the diabetic standpoint. I was looking at it from his lifestyle and just his life experience, because he really, quite frankly, was a miserable man. And you'll go on to see that I don't speak badly of the dead. He's still with us. He went on to have the surgery. He lost a significant amount of weight. He had subsequent regression of his proteinuria and did well. His renal insufficiency improved. The only thing that he was left with was still some visual impairment from the progressive diabetic retinopathy that he had had. He survives today, as I said, and he did well because he had a team of physicians, an approach to his care that was less focused on reacting to each event and more directed at the cause and effect. And he handled his weight loss well, and he was actually thankful and benefited that he was actually able to benefit in that way. And he started to reflect a little bit, thinking about how actually lucky compared to everybody else and the two previous patients that he was. So what he left to me was that even the patients who are the furthest away from you, you can still reach if you fight with them. And lastly, none of these patients were cared for in today's vernacular of population health. They were cared for within a very fragmented and reactionary healthcare system that rewarded volume visits and procedures. Although the outcomes were not being graded at the time, our quality scores weren't really being measured at the time, we were still focused on the outcomes, but they just weren't being aggregated, and we just didn't see them as a common voice. It was something that we thought of individually, but not as a group. As we attempt to move from this fragmented and volume-centered reality into a system where outcomes matter, we need to identify and deal with the barriers. It's really, this is part that really bothers me about some of the things that we hear today. It's simply not enough to say it. We actually have to shift our intentions, and we have to shift the context under which we operate. We can't just continue to say population health. Craig will tell you, I'm not a warm and fuzzy. You probably have already noticed that. I'm not a warm and fuzzy guy. I really work on it, and that's my 360. I know my 360, and my 360 is you got to work on your warm and fuzzy. So I get a little irritated when I hear all the words, but I don't see a lot of the actions. In my administrative career, I've been part of the conversation about patient-centered medical homes, ACOs, bundling, HCAPs, value-based purchasing. I've been part of the conversations regarding physician recruitment, compensation, retention, performance, alignment. And let me tell you, we have an awful lot of work to do in every one of those departments. So what are the specific barriers that I, and actually Craig and I, have worked on in our careers, and you all see every day? These things are embedded. So to me, physician recruitment is a huge problem to try to develop multidisciplinary teams that will care for patients with chronic illness, especially diabetes. You can see by the ramifications of the disease that it hits every organ system, and you really need a team of physicians and a team of experts. They don't all have to be physicians. And in fact, I think non-physicians, advanced practice professionals do, in my experience, I don't want to say better, they do a different and a augmented job. All right, I'll say it in black and white. I think they do a better job sometimes of the endocrinologist of managing these patients. And it's very difficult, but it's hard to find endocrinologists. It's hard to keep an endocrinologist. We have medical staff bylaws that tell us those physicians, if you want to recruit them, they have to take call in your hospital. That's in the bylaws, so they have to do it, or HVAP will get you. So we have to do that. We have to worry about them being inundated with a lot of consults because the hospitalists are trying to get off on their shifts and push the work off onto the other physicians. So the endocrinologist, plus then you have to pay them a lot. And there's not a lot of return on that investment in an annual budget that we're held accountable for. So endocrinologists are very difficult in our experience, Craig will attest, very difficult to recruit. Advanced practice professionals who have the level of expertise that is needed are also hard to find, and they get sucked up by the big systems who have a lot of money. So those of us who are out there practicing in systems that are a little further away from the urban centers, we have a lot more difficulty in building these teams. Worked RVU compensation. It's a volume-based, volume-rewarding compensation system. If we're going to be building teams for population health, we have to get away from the worked RVU system. It's very simple, but we don't do it. And the physicians, quite frankly, have gotten comfortable with it, and they understand it, and they understand it better than most administrators when you start talking to them about their bottom line. And they're very, very reticent to get rid of the worked RVU system, and we have to get rid of it. It's also a disincentive for primary care to refer to the appropriate specialist because they want to keep their productivity up. So it's just a bad system all around if we're truly invested in population health management and chronic disease management. Let's see, value-based purchasing. Well, Medicare and insurance providers are holding hospitals accountable. They've been holding hospitals accountable for outcomes. They're not really holding physicians accountable for outcomes. I get held accountable for 30-day readmission rates. As a hospital, I don't have a lot of control about what's happening 30 days out. I have a little bit of control over what's 3 and 7 days, arguably, but 30 days out, we need to start holding our physicians accountable to the same metrics that the hospitals and everybody else are being held accountable to. Those are barriers for these for us. And lastly, I will just say, population health management is not sexy. Chronic disease management is not sexy. It doesn't get you, it's not a robot. It doesn't have top line revenue associated with it. It doesn't make it, if they're going to talk about it, it's going to hit the cutting room floor at the annual budget time because it just doesn't carry over unless you are playing long ball. And we're not playing a lot of long ball. We're playing a lot of short ball, and we need to change that, and we have to stop talking about this stuff and start doing it. And so in my 20 years of clinical experience and 5 years of administration, it's been my experience that the team approach is the best approach for especially diabetic management. And if we don't even do it for the outcomes and the finances, we should actually do it for the patient experience. Thank you.
Yeah, good. Thanks for the introduction, and appreciate the opportunity to be here to talk to you from the insurance side. I know that inside your bodies you're looking negatively at me right now for representing the insurance company. We're seen as the big deniers in the sky, and I'm here to tell you that we do other things besides deny care. So my name's Rex McCulley, as indicated, and I oversee about 450 nurses at Blue Cross and Blue Shield of Illinois. Some of the nurses do what we call utilization management, but a majority of our nurses do disease management, case management, complex case management. My background is I'm trained in social work and was a behavioral health practitioner for about 15 years before I made a decision to jump into the managed care space, and I moved into managed behavioral health. Worked in that industry for, like I said, for about 6 or 7 years before joining Blue Cross and Blue Shield, and worked in their behavioral health space. And then they asked me about 3 years ago if I wanted to jump out of behavioral health, move to Chicago, and run a medical management program. And I said, but I'm a social worker. I'm not a nurse. I'm not a physician. But I said, sure, I'm up for the challenge. And the primary need that we have with just in our industry, within the insurance industry, is re-examining how we manage and how we look at chronic conditions. A little 101 on how our industry works is a majority of our business comes to us through employer groups who are paying their own claims. We're not paying the claims for, I'll use American Airlines as an example. So American Airlines is a self-funded company. So when their employees go to get care, American Airlines pays that physician. There's a transplant, American Airlines pays for that transplant. And in the old days, in the indemnity days, they would come to us and ask if we would administrate. We became a TPA, a third-party administrator. And so what we would do is just write checks to those providers on behalf of American Airlines, and at the end of the month we settle up. And we call American and say we spent $8 million. That's what you owe us. We'd tack on an administrative fee for all that work, and we would do that. Well, as the patient medical costs began to increase, American Airlines or any of these employer groups is looking at their bottom line, and they're saying, okay, we've got a lot of money going out now in our patient health, in our patient population. What can you do as an insurance company? Because they're not connected to the physician community. They weren't connected to the physician community to have influence or ideas. So they came to the insurance industry and said, what can you do to reduce cost? So we were tasked at that point to look at developing programs. And what we would do first is evaluate their particular employee base, understand at a high level what are some of those cost drivers. You know, maybe there's diabetes or oncology or what have you. And then we would develop programs around managing those chronic conditions. And in the old days, and we're in a transition period to your point earlier, in the old days, those programs, the only way we could connect with people was through the telephone. And so we started hiring nurses to do telephonic outreach. And I think we all know, I know, that this is probably not the best way to engage a member is through the telephone, especially when you have a nurse possibly calling from another state, trying to get a hold of somebody. I never take calls from my own insurance company. I have cholesterol, so I always flag for one of my nurses to give me a call. And when I see Blue Cross and Blue Shield on my phone, I'm not looking at it. But there were enough people, apparently, that did pick up the phone, enough people to make the employer groups feel as though we were really making an impact. So we started hiring nurses, and that worked. Which one is the push button? Oh. And then we hired more, and then we hired more. And so we started really looking at, is this modality of trying to improve patient health and patient outcomes in the chronic condition space really an effective modality? The employer groups who were paying us. So we get paid to do that service. We get paid to pay their claims for them. Then they pay us also to implement a medical management program. So the medical management program of the past, and really still of today, is from an insurance perspective, is based on telephonic outreach. We know, we've always known, and when they invited me to come up to work here, that this is a pretty inferior way to manage a population. It's really not population health. It's more of an individual. This person has this specific thing. And what we were doing is we were working at closing gaps in care. So we would say we could tell from a claim that a diabetic may not have had their A1C in the last year. We could tell from a claim that they hadn't had a foot or an eye exam in the last 6 months or in the last year. And so what our nurses would do is they would call the member. If they answered, they would call the member. They would talk to them about those clinical gaps in care, encourage that member to go get those services done. Also contact the physician's office, leave a message with the front desk and say, you know, patient Sally has got this gap in care. We'd like for you guys to kind of look at that and see if you could resolve that. And when we were on the phone, and when we're on the phone today with members, we're providing them with education, with tools for prevention, with tools to help slow down the disease, the progression of the disease. So cost of care continued and continues to rise in these particular situations. So employer groups still coming to us, wanting us to impact that cost of care. And so what we're moving to now, and I think along with some of the principles of the Affordable Care Act, which I'm not sure will be there tomorrow or in January, but with some of the principles of the Affordable Care Act, including pay for performance and shared savings and accountable care organizations, all the things that we spoke of yesterday, we felt like we were in a real good position to begin moving this nurse-directed intervention back to where it really needs to be, which is in a provider-centric model. And so what we've done in the last year is started really piloting more of a population health management approach, where we are looking at a larger scope, a larger picture of the population that we're charged to help manage cost for. And we're applying analytics to that population to understand what are the overall themes that are driving cost in that particular area. And the ultimate goal in this is that we're working with our physician community and engaging our physician community and turning our nurses and taking them out of the smile and dial work that they do today and turning them more into care coordinators. It's really a full circle back into kind of a community health perspective. So we're taking the nurses and what we're actually doing is we're working with the physician community and saying, hey, we know that you have about 20, I'm using American Airlines just as my pilot program, but you know that you have about 20 American Airlines patients that are in your practice. What we want to do is we want to be able to arm you with the data that we have, because Blue Cross, most insurance companies, have a tremendous amount of data that the physician community may not have access to. So we want to work with that physician, arm them with the data that we have, gaps in care, other physicians that member may be working with where we're getting that information, and partner with that physician and encourage the physician to be meeting with the patient and directing that care and providing those interventions versus listening to one of my nurses who is tasked to write up a treatment plan and then 3 or 4 months later call that member to see if they've followed their little treatment plan that we've come up with, which most of the time getting a member to pick up the phone the second time or the third time is very challenging. So the new way that we're working on this is identifying practitioners who have large pieces of an employer group within their practice. And then if the physician will let us, we want to join that member in the physician's office. Sounds very invasive, but bear with me. Join that member in the physician's office so that we can be there when the physician is speaking to the member and putting those interventions in place with that member. And then to the point that we were talking about at the beginning, is to then join with that member afterwards and be with that member really for a long period of time to explain what just happened, because most of the time nobody's listening to that first initial diagnosis. They don't understand what the treatment options are. Hanging out with that member literally right after the office visit, and then following up with them telephonically. And what we're doing now is we're actually making home visits with members. It's more social work than it is true nurse intervention. But if we need to go out to the member's house to make sure that there's appropriate resources available, do they live in a food desert? Are there no options for healthy food? Do they have enough money for co-pays that they just got a prescription for? Do they need a ramp that the insurance company really doesn't pay for, and can we seek resources to get a ramp built? So the model is moving more towards physician-centric, pushing patients back into the physician's office, not that they haven't been going, but then arming that physician with the data that we have. Another piece of this is as we grow and understand more and more about the population and we get deeper and deeper into analytics, we're able to start doing more predictive things around patients. So we may be able to, we get a lot of claims. We may get a claim from a patient who had a biometric screening at their local place of employment. Well, the physician may not get that information, but those biometrics come into our insurance company, so we know those values. So we may see a high blood sugar. And then we may get another claim from another physician, maybe a PCP that's got same person diagnosed with obesity. Another claim comes in maybe from the endocrinologist or whoever for hypertension. Our predictive analytics is able to say with X percentage of a surety that the next thing that's going to happen in this patient's journey is X. It could be either a procedure or it could be a future diagnosis. And we can bring that information to the physician and to the member as well. The main thing that we're trying to do is in our industry, we have responded to members who have become high risk. We haven't joined them at the beginning of their journey. And the beginning of their journey is where we really need to join them. And with this new model, we believe that we're going to be able to really make some good headway and gain some good results by getting early and being able to educate the members and it's an advocacy model. Be their advocate from the beginning through the end, instead of an occasional phone call, which they're really not that interested in taking. So I think there's great opportunity. We're very excited about furthering our engagement with the provider community so that we can improve patient and member outcomes. I appreciate your time. We're not that bad, I promise. We're not. But I really appreciate your time and effort in coming in today.
I'm happy to be here tonight to talk to you about the awesomeness of advanced practice nursing. And you will find that I am a little biased, but I will try and be as forthcoming as I can. But I have the luxury of overseeing 210 advanced practice nurses and physician assistants right here at Lurie Children's. And I will admit that 4 of our members are physician assistants, not because we don't appreciate the work that they do, but because we've been a really institution that's focused a lot on nursing practice and advancing our nurses. And so for most of you who are in healthcare, I'm sure you know what an advanced practice nurse does and how we get to that credentialing, but I'll just give you a little background to let you know that we're all nurses who have gone on for a master's degree in science and nursing and then gone on to get a postgraduate certificate in our specialty, which may be as a nurse practitioner. Most of our nurse practitioners are pediatric focused. We do have family nurse practitioners as well who have a pediatric component. We can be certified nurse midwives, clinical nurse specialist, or certified registered nurse anesthetist. So those are the 4 components of an advanced practice nurse. In our group, and one of the things that we promote is collaboration of care. It's evidence-based practice. It is working with a team. And in the inpatient side, we very much collaborate with the entire medical team in the way that we provide our care and the way that we continue to take care of the patient through the continuum. On the ambulatory side, we have a unique opportunity to really work collaboratively with our counterparts, with our physicians and providers that refer patients to us, and then also closely along with the other specialties. Most of our patients can have acute illnesses or have chronic illnesses. We have nurse practitioners in every specialty in the hospital. We have over 70 specialists. And so we represent every single area with the exception of dentistry and ophthalmology. Otherwise, we like to think of ourselves as one big happy family, so that whenever there's a need, you can refer to one of the advanced practice nurses within the system, and we seem to have a way to be able to move patients through the system very easily by our own little family that we work in. And so to tie this all together with all the other speakers and everything we've talked about in chronic health management, I want to show you, as you can see, Christina, who's one of our advanced practice nurses. She's taking care of one of our diabetic patients. How do these patients get referred to us? Well, they can come through the hospital system. They can come with an acute episode like Aaron's nephew, or they can come with a chronic illness, maybe referred to us by their pediatrician. But what happens typically is we get that phone call from the referring physician, and they ask to see the head of the division, because that's who their physician referred them to. Of course, if I'm going to send you to a specialty hospital, and if I can't manage your illness, I'm going to send you to the head of the division. Well, that's not always realistic in our timing, as they have other responsibilities, they have a high patient load, they have maybe research and faculty appointments. And so we have instituted the opportunity to utilize advanced practice nurses in these areas so that we can improve our patient access and patients can be seen on a much more timely basis. And we are working very hard with our entire team to be able to promote that to the referring providers that are sending us patients, to say, Dr. So-and-so may not be available to see you for the next 4 months, but we'd love to get you an appointment with one of our advanced practice nurses who is an expert in this area, who can bring you in, assess your child, make a determination as to whether or not they can continue to manage your patient and child, or if they need to be referred to another member of the team. Not necessarily a higher level of care or a different level of care, but to another member of the team, to really clearly define the way that we're utilizing advanced practice as the experts in the field that they're in. So Christina came into this field as a brand new nurse practitioner, but had a lot of experience in taking care of patients. So number one, she has critical thinking skills. Number one, she has compassion. Number two, she has the ability to communicate with the family. And number three, we had to teach her endocrine. We get that in school, but we don't get the specialty like you do in a fellowship or a residency program. So we want to take the time. And she had the luxury of being oriented by an advanced practice nurse who had been in endocrine for 30 years. So what happened to Christina when Betty introduced her to her patients? They cried and they said, I don't want to see Christina. I've had Betty for 30 years managing me. Well, we do have most of our patients who are 30 transition to adult care, but some of them stick around. But before that transition, but they had only known Betty as their one and only go-to person for everything that they needed, because she provided that collaborative care, she provided that compassionate care, she provided their education, and she got to know her patients. So when we have a new diagnosis that comes to us, one of the things that we need to focus on, and which Aaron referred to, was how do we address that patient and what their needs are? We need to be able to assess the learning needs of the patient and the family. So in preparing for this talk, I said, I'm going to go shadow Christina, because I shadow a lot of the nurse practitioners and where they work in their different areas. And let me tell you, I learn a lot in each of these areas. And it's a fabulous experience for me to be able to experience that. And I had a great day spending the time with her, because we saw a myriad of patients. We saw a lot of patients in this mid kind of tween years. We saw some patients who were teenagers, and I really learned about the way that you have to manage each patient individually based on what they bring to the table, what their family brings to the table to contribute to their care, and what they're able to absorb and learn at the time of their diagnosis. So fortunately, this little girl was a chronic patient. She had been with Christina for quite some time. They knew the drill, they knew what was happening, they knew what she was going to ask, they knew how to address the issues, and it was much more a routine visit. Then I had the great experience of a teenager, and I got to see the opportunities and the way that Christina was able to navigate conversations that we have with teenagers. And for those of you who have teenagers, you know exactly what I'm talking about. It's a total process in the way that we address them, and we help them to own their disease and their process. And so we want to bring that all back together in the way that we take care of our patients and families, knowing that we want to prepare them so that they never get to the point where they see Dr. McCormick, that they're never in end stage any organ system failure because of a disease that either really came the way that Aaron's nephew did through a congenital issue, or in the majority of our patients who have acquired diabetes based on their lifestyle and where they are. So we know with children, we have to educate the family, and we have to focus on how we care for the family as a whole, and what foods they have in the house, and the way they manage their insulin, and the way that they manage their diet to avoid ever getting to the point of insulin dependency. So in hopes of bringing this all full circle and showing you the way that we collaborate in the team, we want you to know that advanced practice nurses are something that we continue to move forward in being a collaborative part of the care team, and an opportunity for patients when they come in to have that first experience and say, this is really great. I guess I don't have to see the head of the division because I have someone here who can manage our care. Now in the diabetic population, that care is 4 times a year. They have 4 expected visits a year. We like to make sure that one of those is with the physician that meets the American Diabetic Association criteria. The rest of those visits are managed primarily by the nurse practitioner and the family. So we are available to them 24/7. We do take their call so that families have that opportunity to call at any time. So I hope that this brings things full circle into the entire system and how we all work together to take the best care we can of any of our patients, whether they be inpatient, acute care, or chronic care patients, and how we do work together as a team with our insurance companies to make sure that we are all providing the best care that we can. So thank you for your time.
The CDC estimates that eliminating poor diet, inactivity, and smoking will prevent 80% of heart disease and stroke, 80% of type 2 diabetes, and 40% of cancer. So those are all very hard habits to break, to get up and move more and to eat better. But treatment is important, and we've talked a lot about treatment here today, but how do we firmly entrench prevention at each level of care that we have represented here today?
I'll take a stab at it. I mean, this will expose my political leanings probably. But I mean, education, of course, needs to be at the top of the list. Education early and meaningful and coherent. Infusing private industry into poorer neighborhoods, because you can't tell somebody to go eat healthy. I mean, we raised 3 children. We didn't have a lot of money when they were growing up. Dollar General was a great store because you could buy a bunch of crap for $1 and fill a belly. Making sure that private industry is being encouraged or incentivized to make good, healthy food habits available to people. And then, here's the political leaning thing, easy and affordable healthcare access for all, and so that families don't have to, so that they can seek healthcare and speak with a professional without worry of inability to afford, without worry of inability to understand, and making that healthcare easily accessible and easily affordable.
I can tag on to your education piece and focusing on how we address families and what their readiness to learn is. So we may oftentimes encounter families who are not ready to accept the diagnosis. They're not ready to accept what their future holds for their patient, and we need to stair-step our way into that without hitting them right out of the gate. We know that that happens sometimes in the hospital with an acute illness and episode, that they're just not ready to hear what the changes in their life are going to be. So we want to make sure that we're meeting the patients and families, making their experience what they need, and also meeting them where they're ready to hear things. And so compounding on that each time and being available and accessible to them so that they can come back. I said to my patient today, I said, okay, I'll see you later, but I know when you think of the 10 questions when you walk out the door, make sure you call me and let me know, because that's what happens. It happens to all of us. Regardless of what you're talking about, buying a car or whatever it is, you walk out the door and you think of all the questions that you didn't ask. So we want easy accessibility for our patients, and we want to be available to them.
I would say that's an absolutely huge question, and the right answer there isn't one right answer. Everybody's here. I think the insurance providers, employers all have to be involved. Everybody has to be involved. It's a social question. It's less of a physician question. I mean, it's a much more of a political and social question, I think. But from the physician standpoint, I think perfect is the enemy of good. And I would have chosen one of those and told my patient not to smoke. And I worked with them as much as I possibly could and tried to impact one of those with each patient. So that's my physician perspective. Trying to think I could fix it all is just not going to work. From the administrative standpoint, I would tell you, and part of related to my talk, we have to start changing the context in which we practice. We have to understand this our problems have developed in our current context. So took a visit to St. Louis. You sound like you have Missouri roots. So I took a visit to St. Louis and saw Mercy's Health System's telehealth chronic disease management programs. Absolutely unbelievable. It's like Google of healthcare in St. Louis. It's or Epic in Wisconsin because I like Wisconsin. So it was really very impressive, and I think that we have to start opening our minds to other context of how to manage patients remotely and get them in front. Remember, not everybody lives in Chicago.
Really?
So, yeah, all great answers from the panelists here, and I'm going to kind of piggyback on a few of their perspectives. But my thing is, yes, we got to get to the patients early. We got to get to the diagnosis early, so whether it's earlier access, easy access, cheaper access, but also at the micro level, being that I have a kind of that clinical background, there needs to be bidirectional dialogue with the patients, and we as healthcare and workers, employees, clinicians need to be able to adjust on the fly and address each one of our patients' needs. All of our patients' needs are different. All the communication styles are different. As we know, with different generations, different communication styles are more acceptable, more used. I think we're in a constant state of evolution, and I think we've got to be very creative to reach these patients at a young age. And I'm speaking, obviously, I work at the Children's Hospital, but my stepfather has type 2 diabetes as well, and I have to be very creative trying to get through his thick skull sometimes about the things that he needs to do. And it sounds like I could have used your services at times, some hard love. But no, I think you just got to be creative. I think there needs to be bidirectional dialogue, and you got to be persistent.
And again, we thank them for sponsoring the Chef Leadership Series.
I want to take this opportunity to thank you all for coming out this evening. One of the things I think is really important is the opportunity for us to have this kind of discussion and collaboration. I am also chef president, so at this point I'd also like to take a minute and recognize all of the people that helped put this program together. So if you were part of the Leadership Education Networking Committee to put this together, if you could please just raise your hand so we can recognize you. Thank you. Letting you know a little bit more about Patina Solutions. Again, we are a sponsor of the Leadership Series. Patina Solutions is an organization that really specializes in harnessing the talent of people who have at least 25 years of experience and have served in different kinds of roles in different organizations. The people who essentially make up our portfolio of talent are more from the practitioner side of healthcare. We were founded in 2009. We're a $40 million company, 14 U.S. offices, 4 global partnerships. Our largest practice is healthcare. Our largest office is Chicago. So essentially the kinds of work and projects that we do may be interim, maybe an interim role with an organization, may be permanent, maybe advisory, consulting, mentoring, think tank. But essentially being able to provide a professional who can add a different dimension to a project that's either underway, to a role where there's a vacancy, or perhaps where there's a talent gap. And as we know, healthcare is definitely in a time of transition. And so many times organizations look to us from the perspective of having an A-lister, kind of top of their game person who can walk into a role for a specifically defined period of time. So from that perspective, we're very multi-generational. Again, with the idea of people who have at least 25 years of experience, and certainly would welcome any further dialogue and conversation with you in the reception area as well. And with that, I'm going to quickly just step back into my chef president role and remind you that we are also open now for awards. So one of the things that you'll see on the table when we're out front are ability to submit and nominate your colleagues, someone in your organization, possibly self-nominate people for our awards program, which is open now, and we recognize these winners at the annual meeting, which is in February. So again, information is out, simple admission process, implementation process, one-pager with attachments, and I strongly consider all of you to think about nominating someone you know who's doing great work in healthcare. So thank you so much.
We at Chef hope that you leave here inspired and informed and ready to tackle the most complicated health challenge of our generation.